Well, we're on to YouTube group table 2 because we asked you to look at those different types of regulation, and there's a list of different points up there ranging from self-assessed declarations right up to investigations triggered by complaints or whistleblowing situations. In the NHS, going forward, what balance do you think is appropriate between those different types of regulation? What did you come up with?
Thanks. I got told to say this. Well, I got told I had to say something, I'm not sure what. So my colleagues will put me right when I get what they've said wrong. I mean, I think we found that a very difficult question to answer because we need to think about what we meant by regulation. So one of the questions was what different fields of regulation were we talking about. And we thought we had loads and loads of systems for assessing quality. Well, we weren't very good at using them. That was partly they weren't presented in very effective ways. We were sharing stories of how you get a set of board papers which says it's traffic lighted, and actually you look at the numbers and you say, why is that red? Because the number makes it look amber or green. And we therefore can't rely very much on the quality of the data coming through. But fundamentally, we have lots and lots of information that isn't made usable, and even when it is, we thought the matter of a virtual organisation from this morning was actually quite a powerful one. I mean, I could easily say I have a nice virtual organisation on my board, but I can't easily say whether that reflects what patients experience when they go through. And that leads to a second point, which is that our current processes of regulation mostly bite at a corporate level. So the sorts of things that are described in question 2 would be things that would enable either internally or externally a judgment to be made about how the organisation was functioning. And that doesn't hit very quickly onto the accountability of the frontline staff actually delivering the care. So we haven't got meshed together the accountability for the professional staff with the way in which we regulate organisations. And we're hearing a bit about the question from the airline industry about the balance between, I think it's right, corporate managerial responsibility and the professional responsibility of the engineers and the pilots. And that feels a little bit different from the way we regulate the NHS, where we hold to account organisations and we expect professional staff to deliver the actual services. So that led to a third area, which is around how you could deal with it, address the questions of culture, because not very many of those things that were there would really help us understand what the culture of an organisation was, as opposed to its organisational structure. And we'd started getting into that by asking what value for self-assessed declarations, which as an external assurance is worthless, I think, was the official view from the NHS Litigation Authority.
Gosh, that's strong.
And that then opened up a question about what was the value of the process internally by which things were explored. And that led us to the question of what we meant by regulation. If we're looking for assurance, either external or internal, you need lots of checks on the quality of data. If you're looking for improving the patient experience, an assurance process may never give you that.
Okay, so just to be clear, it wasn't that self-assessment and assurance wasn't important. It wasn't of value in itself to regulators.
From the perspective of the external regulator, it wasn't safe to rely on the fact that an organisation declared itself compliant. You needed the data to back that up. What we then explored was, did that mean that you shouldn't allow things to go on internally? No, it didn't, because actually the self-governance of the organisation was important, but you shouldn't blur those two things together.
On a day when the CQC has announced some results of some spot checks on healthcare organisations and found them to be wanting, it's perhaps interesting to reflect on their proposals for moving to a more regular inspection system. The government have also said that they will be giving powers to Healthwatch to do spot checks and inspections. What are your views on those proposals?
I think both are important. I like what this morning presentation is. Leadership should come from the board, and it is about organized leadership. But other regulators spend a lot of time inspecting the organization. I think it's important for me to hold the mirror. And I think both are important. We've got to get the balance right. But what we should not create a bureaucracy of regulation, which makes your job difficult. Yeah. Too many standards with too many inspections, that makes your job difficult.
Yes, I suppose the differentiation is whether it takes the organisation a long time to feed the beast versus using it as a learning experience.
And one of the important thing is patient feedback. I think most important, one thing I learned from this morning presentation, in a prison, for example, how much they talk to the prisoners. I think that's important.
Okay. Some other comments up here, hopefully away from one of the microphones.
I'm Kieran from the Patients Association. I think surely it's about proportionality, and that you rely on more overbearing, more independent methods of inspection where you think the previous methods haven't worked or they haven't evidence that they can be trusted essentially as an organisation to self-declare. So I think you mentioned the inspections, so that those are inspections focused on really essential standards, basic elements of care, and they found around half of NHS organisations they visited on 1 or 2 wards weren't meeting them. And I think that's not about, you know, having too many standards and people not understanding the standards. A man off the street could make a judgment about whether or not patients are getting basic care. So organisations across the NHS suggested around 50% of them can't manage and deliver that, then surely you need a more externally driven model until the NHS is more better able to evidence that it's meeting standards through a more traditional self-governance model. You should, of course, continue all the self-governance stuff and self-improvement, but actually for a patient, if you have such a high risk when you rely on an organisation itself of suffering kind of the lack of basics, then I think it's proportionate to use a more external method.
So the balance of those methods depends on
the results.
How good
the
healthcare system is at any one time.
Anna Dixon. Just building on that last point, and it was triggered by the prison presentation earlier today, was that it may also need to be focused depending on how capable the consumer, the patient, the user is of voicing their concern. So it's all very well saying we need to, you know, I mean, complaints is a bit too much after the fact, but hear patient voice, whether it be through Healthwatch or more direct means. But when we are talking about, you know, 1 in 4 people in our acute beds having dementia, if we're thinking about those closed institutional environments where people are feeling powerless, we need to think about, in those cases, perhaps being less reliant on just waiting to hear those voices and needing to be more actively in there. So I think it's also, you know, if we're talking about everything from a GP practice through to care homes, we, you know, obviously we need to target the regulatory method in a sense to the institutional context and the nature of how closed it is and how vulnerable the people in it are.
I think that's a really good point, Anna, because I guess in the context of prisons, the prisoners have got nothing to lose, whereas the patients are often quite fearful or not able to voice their concerns. Is that something that you would recognise? Do you think that Anna's got a point about how patients feel about sharing their experiences while they're still in a hospital situation?
Yes, I mean that obviously is a problem, and it's clearly the case too that the most vulnerable are probably not in a position where they can actually express what their needs are at any rate. So, and I think that her whole idea of actually targeting the way in which you regulate very carefully to the nature of the particular organisation and section is important.
Okay. We had somebody wanted to come in over here, and then we should move on.
I'd like to slightly disagree, I'm Peter Venn from the Royal College of Anaesthetists. I'd like to slightly disagree with this idea that you have to have lots of external regulation or leadership from the board to come to that. I think the leadership has to come from the senior clinicians, because if the senior clinicians are not engaged in the process, you're never really going to change the culture in a hospital. And I'd like to just draw, the word consumer was mentioned. I'd like to just draw a parallel between consumers and consumers. In the private sector, and I'm talking about the hospital private sector, the consumer are 2 people. Actually, the consumer is the consultant, because if you do not respond to the consultant as a hospital, he will take his work elsewhere. The consumer for the consultant is the satisfaction of his patients, because if patients go away and criticise the consultant, he won't get any work. And there is a very different ethos to the way things are done in the private healthcare sector. It's not all wonderful by any means, but it does keep the consultants in control, and it does mean that the consultants actually have responsibility for the way that hospital works. And I think that demonstrates that the culture in the private sector can transpose into the NHS sector if the senior clinicians are engaged, and they're really not engaged at the moment. They don't feel they have ownership, and they don't feel they can influence the system, and that is fundamentally what I believe has to change.
Thank you.
Thank you. Eileen Walsh, Oxford Radcliffe. If I could just go back to the issue of powers of regulators and the bit of the elephant in the room, really. The regulators have a lot of powers, but actually in healthcare, I can't remember the last time I actually saw an acute provider in the NHS sector either having their licence suspended or being put out of practice. And unlike some of the other sectors we've heard from this morning, I'm sure that the EDF can actually go out of business. But we've got to take into context all of the political will, all of the extra environment that goes around it, our own communities who don't want to see our services disappear. And actually really think, what's the point in giving regulators powers if then we don't have the stomach to allow them to use them?
Yes, it's a very interesting point to reflect in the context of mid-staff.